My name is Alexandra Carroll, and I'm a second-year medical student at EVMS. Today I will be presenting research done by Dr. Bakri Kula, Dr. Bryn Sheehan, Dr. Patrick Haggerty, and myself. The title of our research project is A Retrospective Evaluation of Three-Step EIA-PCR Algorithm as an Effective Method for Detection and Treatment of C. diff infection. First, I'm going to discuss some background on C. diff infection, also referred to as CDI. CDI is the primary cause of infectious diarrhea in the U.S. Timely and accurate testing provides the guidance that physicians need to determine how and when to treat a patient. Previously, the local hospital system performed a less sensitive GDH toxin IEA detection method. Starting July of 2013, the laboratory service utilized a more sensitive three-step algorithm to detect CDI. The algorithm detects GDH, toxin A and B, and proceeds with NAAT PCR testing for samples that have discrepant results, meaning positive for only one test, GDH or toxin A and B. Our retrospective study was designed to determine rates of positive CDI and compare rates and outcomes of GDH positive, toxin positive, what we will refer to as a true positive, and GDH positive, toxin negative patients who are subsequently PCR positive, what we will refer to as an indeterminate positive, based on CDI severity stratification. Our methodology for this project included a retrospective chart review that was performed for all patients who presented with hospital-associated diarrhea and were admitted to Sentara Norfolk General Hospital and then subsequently tested for CDI from September 1, 2016 to September 30, 2017. Cases were detected using the three-step algorithm previously described. Multivariable chi-squared tests were performed to compare CDI with medical history, outcome measures, treatment-related variables, CDI treatment, and blood test lab values. First, we determine overall rates of CDI cases based on GDH, toxin, and PCR results. We then determine person-level frequencies and chi-squared results between true positive and indeterminate positive groups. We then found the sample descriptive of age, length of stay, and ICU length of stay. Lastly, independent sample t-tests were found between true positive and indeterminate positive groups. 1,031 stool samples were tested for CDI. Of them, 853 were negative, 178 were positive. This included 265 GDH positive tests and 94 toxin positive tests. Specifically, the incidence of true positive was 94 and indeterminate positive was 84. The first positive or first test from each patient was included to ensure independence of data points. This resulted in 830 unique tests and patients. When comparing outcomes for true positive tests to indeterminate positive tests, groups did not differ on a variety of demographics, clinical variables, and various lab values. The groups were found to differ on initial treatment used, with true positive cases being more likely to receive both Metro and Vanco treatment as compared to indeterminate positive cases. When comparing the true positive to indeterminate positive groups, we found that the results did not differ on most variables. However, we did find that the groups differed on initial treatment used. Additionally, we found evidence that performing the three-step algorithm prevents nearly half of GDH positive, toxin negative patients from being unnecessarily treated with antibiotics. By preventing unnecessary antibiotic use, the three-step algorithm effectively decreases cost per patient and length of stay. That is all, and thank you for your attention.